Good evening, ladies and gentlemen. I'm very pleased to welcome you to this episode of the IMWG conference series, coming to you from Orlando, Florida, the site of ASH 2015, Making Sense of Treatment. I'm very, very pleased tonight to welcome my colleagues and friends who are at ASH. I'm glad to see them looking still alert and smiling. They have all been active since very early this morning. The official meetings start at 7 o'clock, and Paul just finished a poster session moments ago. And there have been meetings starting at 6 on a regular basis for several days. So very pleased to see you all here. To my immediate left, I have the pleasure to introduce Joseph Mikhail from the Mayo Clinic in Scottsdale. To his left, Antonio Palumbo from the University of Torino in Italy. And directly opposite me, of course, Paul Richardson from the Dana-Farber in Boston, Massachusetts. So welcome. And let me show you what we're going to talk about tonight. We're very pleased to have 4 topics for discussion. And these are topics which have really been prominent in many abstracts this year at ASH. And I think that the information is making it quite complicated to have choices for treatment. It's wonderful to have new drugs and to have new options, but now we need to really sort out how to have the best use of all these drugs and all these options. So, first topic, MRD testing. Is it ready for prime time? A lot of abstracts on that. Frontline therapy, many presentations of different options. What are the best options that our panel here would recommend this year and moving into next year? For relapse, we have 3 new recent drug approvals that we'll talk about. But how do we prioritize these new choices? And having approved these 3 new drugs, how do we look at new agents coming along? How are those going to be assessed? How are we going to look at this approval process for new drugs coming along? So let's start with the first topic. MRD testing. Is it ready for prime time? Okay. So this year at ASH, there were close to 800 abstracts. Of those, there were close to 30 that dealt with minimal residual disease in some fashion, looking at different tests, molecular tests, flow cytometry, assessment in different trials. I've listed here what were the 10 total number of top topics, molecular testing, approved drugs, and then some of the newer drugs. We're very, very pleased also to have Paul here tonight. He was one of 2 recipients of the Beutler Lecture Award this year, so congratulations, Paul. Very well deserved.
Thank you.
And this was obviously linked to the proteasome inhibitor story, so very, very nice.
Thank you, Brian, very much.
So for the minimal residual disease aspect, I've listed here the oral and poster presentations for those of you who may be interested. I've highlighted some of the aspects that came up for discussion. Obviously, depth of response is really a key aspect and is being linked increasingly in a variety of trials to better outcomes. There are different ways to assess depth of response, and we now have next generation sequencing, next generation flow, also imaging. There are aspects related to the evolution of multiple subclones over time. What would be wonderful would be to have a blood test versus a bone marrow test, and many new methods are being looked at and many new trials being designed. One abstract that really had a lot of attention with a couple of presentations just on this one protocol is the IFM Dana-Farber joint protocol. And this aspect was presented by Hervé Abbott-Lusseau, looking at the outcomes of this trial, which is the VRD plus or minus transplant. The key aspect that we'll talk in this first section about is just the outcomes for patients who achieved a deep response. And it was very interesting to see that in this case, using an MRD test with a sensitivity at the 10 to the minus 6 level, clearly a much better outcome related to those patients who were positive. And so this really brings MRD testing up to current speed and evaluable in the trials that we're most interested in. In addition to this, there has been the evolution of the flow technique with the development of the next generation flow, and several papers were presented at this meeting indicating a sensitivity with the 8 antibody panel at a similar sensitivity down to 10 to the minus 6, and also with a multi-dimensional software package giving output in now 13 minutes. So this is a helpful aspect to that. And so there was a comparison conducted by the Spanish team comparing the next generation flow with the NGS. And in this particular analysis here, the NGF actually won out with 2 positives here that were actually negative on the NGS. The other aspect here that, as my colleagues here know, NGS is not technically possible for every patient. And so around 10–15% of patients, the test is not feasible. I think the reasonable assessment of this is that the 2 tests are rather equivalent in terms of sensitivity, I would say, because these tests are difficult to do where you have enough material to do both testings on the same sample. Now, in sync with this, we now have, I think, an agreement. The final manuscript, what we hope is the final manuscript, is in circulation on the new criteria for MRD, in which these levels of response assessment are integrated in a standardized new response criteria setting. And so Shaji Kumar has been taking the lead on this, and important aspects of this are the 3 elements of assessment of MRD. There is a new category here of sustained MRD, which is indicating sustained MRD for at least 1 year with 2 readings, which requires that both either flow or sequencing be negative, with a quantitative assessment at the 10 to the minus 5 level at least. For the sustained MRD, imaging by PET-CT also needs to be negative. It is emphasized down at the bottom here is that if we are going to be using MRD, it is a priority to use those samples for the MRD testing. But what is the centerpiece of what we're looking at now is this 10 to the minus 5, the 10 to the minus 6 level sufficient to really achieve a sustained response and potentially a cure or a functional cure? And Antonio was part of a debate on Friday about this, whether this is indeed something that's correct or not. We do know that at the 10 to the minus 4 level, there are definite relapses. Indicated here are the yardsticks that could be used to consider functional cure. 1 year sustained, 3 years sustained, 5 years sustained. The Salamanca protocol assessing treatment in the high-risk smoldering myeloma setting to achieve possible cure is using the 5-year as the endpoint for assessment. But the truth of the matter is that we really need to keep looking in trials to see what both MRD negative and MRD positive mean. We need to know if you're MRD negative, can you stop maintenance? If you're MRD positive, do you need to continue with maintenance? And some trials which are even a little bit more sophisticated than that are needed. So this is the kind of trial that can really properly answer this question. If you're MRD positive, you need to look at no maintenance and maintenance. And likewise for negative, do you need to continue a little bit longer with maintenance or stop? And so the question really is, where are we in terms of MRD assessment? Is it ready for prime time? Is it to where we can have some very nice trials to assess it? And so the question is, where are we? Is MRD testing ready for prime time? We're certainly seeing lots of abstracts. And how would you recommend using it at the present time? Antonio debated this on Friday, but maybe I'll ask Joe first.
Sure.
What do you think? And then I'll have Antonio jump in and Paul. So
I'm happy to debate Antonio over it. No, but well, I think you captured it very well. The fact that actually there are that many abstracts tells us that one, there's a lot of interest, but there still isn't a complete commonality. So
yes.
when we discussed this very issue last year,
yes.
there was a sense that flow is doing it this way and next generation sequencing is doing it this way. There wasn't a common currency. I think we're a lot closer to it. I think we're learning from MRD that it is a tremendously prognostic tool. It can help us understand prognosis, and it's much more a diagnostic tool in understanding the depth of response. But I would say we're not quite ready for prime time in the clinic, meaning we're still not sure that if I see a patient who's MRD negative that I feel comfortable saying, let's stop treatment. Or by contrast, if I was planning to stop treatment, if there's some element of MRD positivity that I immediately have to say, oh, no, you must continue on treatment. But where I think we're ready for prime time now is to apply either of these modalities, flow or sequencing, to our clinical trials, or perhaps even addition to that, to centers or places that are collecting databases, where we can say and look and interrogate databases and say, this is what happened when people did and did not receive this kind of maintenance therapy when they're MRD positive or negative, which could inform the future. So we're a whole lot closer to prime time. I don't know, maybe we're sort of in the afternoon slot, like we're not quite ready for prime time yet, but I'd say that we're getting a lot closer than we were even just a year ago when we had this discussion, let alone even 6 months ago.
Right, and so on Friday, I had the sense that Antonio was not sure if we were even in the afternoon slot or not. But
no,
what do you think?
This time I cannot make a discussion with my friend Joseph, so...
It's okay, we have lots of other topics later. We're getting warmed up.
We will get later on. My comment is, depends. Depends what do you mean by MRD. MRD is certainly the next generation definition of CR. So from this point of view, the prime time is today. Because certainly immunofixation negative CR has a sensitivities of minus 10 to minus 2, and now we are able to go to 10 to minus 6. So this is the next generation and is a prime time today for the new definition of CR. Now, is a prognostic factor? No question, because reaching CR or reaching MRD negativity is a major prognostic factor that will predict the outcome, and that's absolutely yes. There is a prime time to define today if this is already a tool to say, I stop treatment, I restart therapy. No, and from that point of view, I guess we are in total agreement. And basically, this is the difference. We need some more time, and I completely agree with Joseph, we need some study to really define how to change treatment according to MRD negativity or positivity. I would like only to add another issue that I think is important and is coming along with the MRD testing. And the issue is that today MRD is not enough. We do need to add imaging in the definition of MRD. And as it is in lymphoma, there are some important data coming from the French group saying that even in MRD negativity, you still have 20 to 30% of patients who did show positivity on a CT PET imaging scan. So I think what the message, the take-home message today is MRD is the next generation definition of CR, but also we need to introduce in this definition the new tool, the CT PET for imaging, for also exclude positivity that may be present in other locations. So we have to use both, both tests to really define if a patient has a very, very, very profound cyto reduction.
And there's definitely some way to go in terms of standardizing the imaging part of this. What is the SUV cutoff for the PET scan and things like that? And so Actually, we're very pleased. We're collaborating with the German team in Heidelberg, where they're really making an effort to do that, and they have actually even started to take the digitized information into a software program so that it could really be quantitated and used in a more standardized way. So there's a ways to go in assessing the imaging piece. So Paul, what is your take on this?
Well, I completely agree actually with Antonio, and I shared Joe's concern about saying, is it prime time? I think it's a very useful and important research tool going forward. The work we're doing with the IFM group absolutely corroborates what you're saying, Antonio, that the imaging matters. And I think that my concern about MRD quote-unquote negativity is that it allows, or it opens the door to a sort of therapeutic parsimony. In other words, that you should stop treatment if you're MRD negative and not be on any treatment whatsoever. Right. And everything clinically in my bones tells me that literally in my bones, is telling me that that may not be wise. And I'm always reminded with the old statement that a fool with a new tool is still a fool. We've got to know what this means. So I think MRD negativity matters in the context of clinical research. It's a very important forward direction. I just want to make sure that we don't get ourselves into the bind where, regulators and others who would like to see us, not treat patients, be in a situation where, we start getting ourselves cut into alleyways that we don't want to be in.
Yes, to stop treatment prematurely.
Prematurely, and not only prematurely, but we've learned at this meeting, and we'll talk about this in a moment, about the value of immuno-oncology. And clearly the immuno-oncology we've been sitting on for the last 15 years are the IMiDs. And what I wouldn't want to see is that there's a move to say if you're MRD negative, you cannot be on a treatment. That to me is a strange way of looking at this. My view is that if you're MRD negative, it may mean that you can have minimal therapy, or you may not need 3 or 4 drugs, you may need just 1. Exactly. But I want to be very careful about how we approach that, because I think we could go backwards.
So the Spanish team actually have an idea of helping to assess that also, so that one advantage of the flow method is that you can also look at the microenvironmental cells, so that you can look at the normal B cells, the T cells, the T17 reg cells, and things like that. And so as you are achieving a deep MRD negative status, you can also look at the recovery of normal B cells and some of those things which are indicators possibly of the impact of an immunostimulatory or immunoenhancing, an IO effect, but also maybe a better correlate of a truly long or sustained remission.
Yeah, I completely agree, Brian, and I think the other interesting point is that, what you showed about flow, that's fascinating, that this next generation flow is generating some evidence that there's not concordance with next generation sequencing, NGS.
Yes.
Because I recently saw a patient in which her sequencing was negative, but her flow was positive.
Yep.
And guess what? She had an elevated kappa light chain. And everyone was looking at her saying, MRD negative, do nothing. And I went, whoa. And guess what? When we reintroduced some maintenance, kappa light chain normalized, she was fine, onward and upward.
So I'm certainly sensing from all of you that we're not ready to be using it for decision making in the clinic.
But I think information gathering is still critical.
I couldn't
agree
more.
I'm so glad that the trial that I know we're going to be discussing more, the IFM DFCI trial, is capturing that a priori as we're going along.
And that's excellent.
And that's brilliant.
That's excellent. Yeah, it's
otherwise
key.
it's impossible.
I couldn't agree more.